session of Smilow Shares. As you all know, our focus tonight is on lung cancer, specifically lung cancer update. And we are very happy to have with us Emily Kopas, our nurse practitioner who has been organizing and running our lung cancer screening program. We have Dr. Justin Blasberg, our thoracic surgeon, and joining us a little later will be Dr. Bruce McGibbon of radiation oncology, and I am Sung Lee. I'm one of the medical oncologists here in Greenwich. So thank you very much, everyone, for joining us. And we'll start off the program tonight with Emily, who's going to tell us about lung cancer screening. Emily, it's all yours.
All right, I will share my screen. Can you guys see my screen?
Yes.
Okay. All right. Again, my name is Emily Kopas, and I am the lung cancer screening coordinator and nurse practitioner here with our lung cancer screening program in Greenwich. So the mission of our program is to provide an integrated, comprehensive and interdisciplinary lung cancer screening program. We are comprised of a team of pulmonologists, chest radiologists, a thoracic surgeon, medical and radiation oncologists, as well as smoking cessation specialists. So lung cancer screening is really a process that needs to take place in order to efficiently screen people for lung cancer. Just a couple of statistics on lung cancer. It is estimated that there will be 236,740 new cases of lung cancer this year, and only 16% of these cases are diagnosed at a localized stage when the 5-year survival rate is 56%. And this is in contrast to the 47% of cases that aren't caught until a later stage when the survival rate is only 6%. It is projected that there will be 150,000 Americans and 1.8 million people in the world that will die from lung cancer this year. So as you can see, lung cancer is really the most curable when it's diagnosed at an early stage when the 5-year survival rate is the highest. Most people at this early stage do not have symptoms. So this is why lung cancer screening is really so important and how we can positively impact patient outcomes and change these statistics for the better. So lung cancer screening was recommended for eligible patients based on a couple of studies that had been conducted. One of them was the NLST trial, which was conducted back in 2011, and it evaluated low-dose CT scans in comparison to chest x-rays. So participants were randomized into two groups, the chest x-ray group and the low-dose CT group. And the results actually showed a 20% decrease in mortality from lung cancer in the low-dose CT group in comparison to the chest x-ray group. So in fact, the low-dose CT group was more effective in detecting lung cancer than the chest x-ray group was. Another study that investigated the benefits of lung cancer screening was the Nelson study. And this showed a significant reduction in mortality in both males and females. However, there was a significant reduction in mortality in women especially. So the majority of lung cancers are diagnosed in stage 1 in both of the two studies that I just talked about. Screening is not currently available to everyone with high risk factors at this time, unfortunately. However, I am going to talk about those that are eligible for free lung cancer screenings in the upcoming slides. So screening, regardless if it's for lung cancer or if you're getting your mammogram or a colonoscopy, it is the evaluation of a disease in the absence of symptoms. And screening is best when outcomes are better when the disease is detected early and when the benefits of screening outweigh the risks. So Medicare and Medicaid officially started covering lung cancer screening with low-dose CT scans back in 2015, and other commercial insurance companies have also started covering low-dose CT scans. USPSTF recently updated their recommendations back in 2021, and now Medicare and Medicaid are officially covering this expanded eligibility, which includes those between the ages of 50 to 80. Currently, Medicare and Medicaid will only cover up until 77. However, most commercial insurance companies do cover up to the age of 80. Patients that have a 20-pack year smoking history, which is equivalent to about a pack a day for 20 years or about a half a pack a day for 40 years, are current or former smokers. And if you have quit within the last 15 years, you're eligible, and no overt signs of lung cancer. So any new respiratory symptoms like new onset shortness of breath, or any unintentional weight loss, or any new cough where you're coughing up bloody sputum. So this new criteria actually doubled the amount of people that are eligible for lung cancer screening. So this slide just compares a chest x-ray to a low-dose CT scan. And as you can see, the picture on the right is the low-dose CT, and it is a much clearer picture, and it illuminates the vasculature, and we can really clearly see what's in the lungs. And we're looking for spots that we call nodules, and they can be benign, but depending on the size and the density of them, they could be a little bit suspicious for lung cancer. So the low-dose CT scans do a really nice job of illuminating these nodules, where on the chest x-ray, they're not as clearly seen, and sometimes they can go missed on a chest x-ray, which is why the low-dose CT scans are recommended for screening. So all patients that are ordered an initial lung cancer screening scan meet with me for a shared decision-making visit. And it is fairly quick. It can be telehealth or a phone call. And we just review that the patient is eligible, and that insurance will cover their scan. We also have a discussion about the individual's benefits and risks of screening to make sure they want to go ahead and proceed with their scan. I also provide them with a personalized lung cancer risk evaluation using the Tamamagi risk calculator. I also stress the importance of patients adhering to annual screening as long as they are eligible. And this is because there are different types of lung cancer, but some of them grow very quickly. So it is really important that we monitor people within a yearly basis, as long as that is the recommendation. And all patients qualify for our free smoking cessation program as well. So this is just a little bit of information on our free smoking cessation program. So patients are provided with free nicotine replacement products, and they also are able to participate in weekly phone calls or telehealth visits just for counseling and support if they are interested. So this is a picture of a CT scanner. And as you can see, it's open. So patients who are claustrophobic usually tolerate it pretty well. The whole scan takes maybe 5 to 10 minutes at most. And you basically will lie on the bed, the table, and then they'll ask you to take a deep breath and hold it for a couple seconds, and they'll take the picture. There's no contrast dye or any IVs that are used. And the radiologists utilize the LungRad's scoring system to read all of the scans. So this is pretty hot off the press. LungRad's has recently published a new version that just came out last week. And all scans are read with this LungRad scoring, and they are given a recommendation for follow-up, which is based on the size and the density of the lung nodules. And this provides a standardized reporting and follow-up system. So all patients that are assigned a 1 and a 2, the recommendation is that they receive yearly follow-up. And then patients that receive a 3 or a 4 on their scan, it is recommended that they receive a 6 or 3-month follow-up. And it really does depend on how many nodules that are seen, the size of the nodules, as well as the density. And this LungRad's version is very similar to the previous one, However, there is a new classification that includes recommendations for atypical pulmonary cysts. So what are some of the barriers to screening? It is estimated that there are about 14 to 15 million people that are eligible for lung cancer screening. However, currently there is less than 10% of people who are eligible are actually getting screened. A large contributing factor to this is a lack of awareness. Mammogram and colonoscopies have been around for many years, and they're very well utilized. However, lung cancer screening kind of came late to the party back in 2015. So we're still trying to get out into the community and spread awareness on our program, and that lung cancer screening programs do exist. Stigma can also serve as a barrier to screening. Some people aren't necessarily willing to have an honest conversation with their providers about their smoking history. I just want to make it clear that we do not judge anybody based on their smoking history at all. We really are here to help them and meet them at where they're at in their willingness to quit. The fear of the test, radiation exposure can be a limiting factor, which I'm going to talk about in the upcoming slide. The fear of a cancer diagnosis, as well as fear of surgery and treatment. And as we going to hear later tonight, when lung cancer is detected early, sometimes more of the systemic treatments might be able to be avoided, as well as competing health and financial demands can serve as a limiting factor as well. But again, as long as you fit the eligibility criteria, your scan will be covered. And this slide just shows a nice comparison of the amount of radiation that you were exposed to with the low-dose CT in comparison to some other scans that are ordered, as well as environmental exposure. So a low-dose CT scan is a little bit about less than 1 millisieverts, which is very similar to the amount of radiation that a person receives when getting a mammogram. It is significantly less radiation than a full CT scan. It's equivalent, one CT scan is equivalent to about 10 low-dose CT scans. And there is radiation exposure with transatlantic flights, and it is equivalent, one scan is equivalent to about 7 transatlantic flights. So there is radiation exposure, but it is pretty minimal. I also just want to mention, in addition to our program here in Greenwich, patients can also get screened in our Long Ridge location in Stamford, as well as Yale has a program in New Haven, Bridgeport Hospital, and in Trumbull, as well as Lawrence and Memorial and Westerly. And all of our programs work cohesively, and we meet weekly to review how we can potentially improve our programs. And this slide just shows the 3 different orders of lung cancer screening scans. The first is obviously the initial. So if you've never had a scan before, this is what your physician would order. A subsequent is for patients that are already enrolled in the program that receive a recommendation for their yearly follow-up. And then the lung cancer screening nodule follow-up is used for patients that receive a 3 or 6 month recommendation. And here is my contact information, as well as Dr. Blasberg's. I encourage, if you have any questions or concerns, feel free to give me a call. And I also just want to mention that even if your provider might not necessarily be part of our system or using our electronic medical record, they can always fax the order form to us, and we can get you connected and scheduled for your scan. And with that, I will let Dr. Blasberg present now. Did you guys have any questions for me, or should we do questions at the end?
I think we should do questions at the end.
Okay.
And also, I think our audience is welcome to type in any questions, and we'll try to field them as we go along. So, okay. Emily, thank you very much. That was great. And now let's, we'll give
Emily,
it forward to
you did. Okay, great.
Dr. Blasberg.
1 second here. Let's see if I can get this to work. You guys can see my screen okay?
Yep. You're good.
So good evening. My name is Justin Blasberg. I'm one of the thoracic surgeons at Yale New Haven Hospital and Greenwich Hospital. I wanted to let you know a little bit tonight. I'm going to talk a little bit more about lung cancer screening and also opportunities to treat patients with surgery who have early stage lung cancer. As many of you know, and as Emily sort of talked about, lung cancer is really a big problem in our community. It's not the most common cancer out there compared to, say, breast or prostate cancer, but unfortunately, it's much more lethal. And as a result, it's the #1 cancer killer in the United States. The main reason for this is mostly because patients are diagnosed at an advanced stage when they present to their doctor with symptoms. And really, the goal of tonight's presentation is to send out a message to this audience that we're working to try and change that, to try and change this bar chart that you can see here, to get more people into the column of localized disease, meaning early stage disease, so that we can offer them treatments like surgery or radiation at earlier stages, and hopefully give patients a better chance of surviving this problem. So Emily touched on lung cancer screening. What is lung cancer screening? It's a test to detect lung cancer before a patient develops symptoms. I showed you the bar chart in the prior slide. When patients present to their doctor with symptoms, they're more often found to have advanced disease. So the purpose of screening is to identify the patients who are at highest risk for lung cancer and to offer them a test that might pick up those cancers at earlier stages and before symptoms actually develop. Prior to 2011 or 2013, there wasn't a clinical trial to support lung cancer screening with CT scans. And most physicians were just using chest x-rays to look for cancer without any significant benefit to patients. As Emily mentioned, in 2011, the famous, now infamous lung cancer screening trial, the NLST trial, looked at comparing chest x-rays and CT scans and defined that in the right population, that CT scans pick up cancers in earlier stages. And in doing so, we realized about a 20% benefit or a 20% reduction in lung cancer death, meaning patients are less likely to die from lung cancer. So this was pretty exciting data, and it serves as the foundation for our lung cancer screening program and our efforts to offer patients who have a history of smoking, patients who are active smokers, or otherwise who meet our screening criteria that we've discussed, the opportunity to have a screening CT scan and to be followed in our program. Emily touched on the benefits of screening a little bit. We're hoping to detect lung cancer in earlier stages when it's more curable, and ultimately to decrease the chance that patients would potentially die from lung cancer. This is a highly underutilized resource in the United States. There are over 7 million Americans who are eligible for lung cancer screening. Less than 4% have undergone screening. And this is probably an old statistic with the expanded indications released last year, but it still remains a new opportunity for patients compared to other screening tests like mammography and colonoscopy. We talked about some of the risks of screening. Probably the most concerning to patients would be finding a nodule that isn't cancer, or seeing a nodule and worrying that it could be cancer. Almost 95% of our incidental nodules on screening CT scan aren't cancer. This can lead to a significant amount of anxiety on the behalf of patients when it comes to follow-up, potentially a biopsy of a nodule, or in some cases surgery, because a nodule is suspicious and it should be removed. And so we do our best to sort of work through this process in terms of when we find a problem, to sort of talk about what our suspicion is for that problem and to work towards figuring out what this is. There's also a risk of false negative. A younger patient who may qualify for screening may get a scan that shows no abnormalities at all and then feel like they're good. They don't need to worry about this and never get another scan in the future. And that lung cancer could develop over time. So it's important to think of this not just as a single scan, but really a relationship with our lung cancer screening team, so that there's appropriate follow-up scans, and that these are performed over a recommended interval so that we can screen for potential new problems that pop up, not just a single scan and then you're done. Patients are often worried about getting extra scans and the radiation exposure, and Emily touched on that, so I think I'll skip that. And the costs as well. This is covered by Medicare and therefore covered by most insurance companies, private insurance companies, with minimal cost sharing. But before patients undergo CT screening, there is a insurance authorization, and so you're fully aware of any potential cost sharing responsibilities that might exist. it's most often the case that there are none. So when you get a scan, what do the results mean? Usually there are three possibilities. One is there are no nodules, no abnormalities, and there's generally a recommendation for an annual low-dose screening surveillance CT scan going forward on an annual basis. Number two is that there's a nodule or spot that isn't clearly benign. It isn't clearly cancer. We call it indeterminate, and we discuss these cases as a group and consider either a short interval CT scan, a repeat scan that's say 3 to 6 months, or potentially even a biopsy under circumstances where we're more concerned about the nodule and we think that it needs to be investigated further. The third option, or the third possibility, is that there's a very suspicious finding that we think is highly likely to be cancer. And then in these cases, we'll pursue additional testing and discuss these cases in our multidisciplinary tumor board so that we can help patients understand what their treatments are and to pursue those. We talked about the lung cancer screening trial, and as a result of that, the United States Preventative Task Force released recommendations in 2013 for screening, and these were revised in 2021. And Emily has covered these criteria, but you can really never see them enough to you have to meet all of these criteria in order to be recommended to a screening program. But if you do, if you're a current or former smoker who quit within the last 15 years, if you meet this age criteria, and if you have a 20-pack year smoking history, you're eligible for free screening and you should contact us. Once we find a lung cancer, so I'll transition a little bit more into the treatment side. And I have fun videos or more fun videos than I do pictures. So hopefully there's some entertainment value to the presentation here. But I would say once we find a lung cancer, we get together as a group, this group that's here, and we discuss the best available treatments in a multidisciplinary format. For patients with early stage lung cancers, which means they have small tumors in a very specific location, surgery or potentially radiation are the go-to treatments for early stage lung cancer. For patients with more advanced disease, you'll meet with our medical oncologist like Dr. Lee and talk about other treatment options, including chemotherapy and immunotherapy or targeted therapy. And I think Dr. Lee will talk about that a little bit more later. So if you have lung cancer and surgery is your best option, you'll meet with a thoracic surgeon like myself, and we'll talk about treatment. Our traditional approach to lung cancer surgery was to make an incision about 6 inches long to get through the muscles in the chest wall, to spread the ribs with retractors so that we could access the lung with our hands and perform resection under direct vision. Screen right is a scene from one of my favorite shows on Netflix, The Crown. King George IV actually underwent this kind of surgery inside of Buckingham Palace in 1951, which is pretty impressive. Sometimes this kind of incision and surgery is necessary because of where a lung cancer is located or its size. And after this kind of incision, the incision can be uncomfortable for some period of time. Patients may need to stay in the hospital for So robotic surgery, at least in lung cancer, represents an opportunity to bridge the gap between the advantages of open traditional surgery and minimally invasive surgery by combining those techniques. The advantages of open surgery, but through small incisions, that allows us to realize a shorter hospital length of stay, less pain after surgery, quicker return to work, and overall quicker return to baseline function. So this platform lets us do all of those things that we do when we're doing open surgery in terms of the advantages and the components of the cancer treating aspects of the operation, but in a way that's much better for patients. So it's become our preferred technique. If you've never seen what robotic lung surgery looks like, a surgeon sits at a console controlling robotic instruments. These are inserted through through keyhole incision ports. Instruments attached to these ports, and then using robotic controller arms, we can move those instruments around in the same way that we move our hands around. They can perform complex functions, and essentially they perform the same technical function as if my own hand was doing the operation. So I move these instruments around using hand controls, which you just saw. They let me dissect around the lung, dissect out important structures. And these are basically the same motions as if I were performing the operation at the bedside, except that I'm looking at it through much higher magnification, using 3D imaging, and it lets me do the operation in a very safe way with a relatively short length of stay in the hospital compared to open surgery. So a big improvement compared to King George IV. And as this technology gets better, it also gets smaller, which is really exciting. This is a single port robot that's in use within our network. Instead of 4 separate incisions for 4 instruments, this platform allows for a single incision that contains all 4 instruments. For surgeons who work in the abdomen, they can hide an incision in your belly button and remove your gallbladder without compromising on safety or quality. And there are applications for this in the works for thoracic, lung, and mediastinal surgery as well. So we're really excited for these kinds of opportunities, mostly because we think it'll help patients recover more quickly. But also, this is clearly where the direction where small incision surgery is going, and we're fortunate to have this technology for our use. Additionally, we've been fortunate to acquire a robotic bronchoscopy technology that allows us to biopsy lung nodules that may be difficult to access by traditional means. We also now have this technology for use, where we can direct a flexible robotic catheter, drive it out to a lung nodule using a computer mapping technology, get to a nodule, as you can see in this video here, and either biopsy it or mark it so that when we're in the operating room, we can find these smaller nodules that may be difficult to find otherwise. So I would say overall, there's a lot of exciting opportunities at Greenwich Hospital, both in terms of lung cancer screening and surgery. And with that, I will hand off the baton to, I think, the Norm Roth Leadership Award winner, Bruce McGibbon, who was recently crowned 15 minutes ago with that honor. So congratulations, Bruce. And I think we'll take questions at the end.
Thank you so much, Dr. Glassberg. Let me see if I can share my screen here and set this up. All right, can you guys see my presentation there?
Yes.
Yep.
Thanks. Okay. All right, very good. So I'm going to give some updates here as pertains to radiation therapy for lung cancer, and mostly with early stage stuff, but a little bit of later stage, and just some kind of newer highlights. And happy to answer any questions later too. Don't have any disclosures. One of the things which is really been most impressive in radiation therapy, if we go back to 10 or 15 years ago plus up to the current time, is image guidance. And before, what happened is, we would be able to use CAT scans and things to start to design your treatment, but then in the room, we'd have to use much bigger margins around where we're trying to treat to make sure that we weren't missing. How we're going to account for how the tumor moves with breathing. Most radiation treatments take, in terms of the beam actually being on, something like 3 or 4 minutes. So clearly we want you to be breathing through the treatment. So how do we know where the tumor is that day, and how do we account for its movement? And this image-guided radiation therapy has really put us really far ahead. And the left side of the screen here, we have this split view where the top left and the lower right are from our actual CAT scan that we use for planning purposes, and the top right and lower left are from what's called a cone beam CT, which is, as you can see, looks very similar to a CAT scan. It's just slightly grainier. And we overlay these two with the patient actually on the table for a given treatment and go back and forth and make sure that we're properly lined up that day. And by doing that, this is allowing us to have a better chance of controlling and curing the tumor, and is allowing us to have tighter margins so we can stay away from things like the spinal cord, which is in this cyan color here, or the main airways, which are in yellow there, or the heart, or any number of structures. So this has been a really big advance for us. The picture on the lower right is the type of machine that we have here at Greenwich Hospital, which is one of the industry leading machines. It's called the Varian TrueBeam. And just for interest's sake, I'll point out that this part of the machine here is the head of the machine. This whole thing's called the gantry, and that's where the radiation comes out of. And these little arms off to the sides are what do the imaging and create that cone beam CT. One of the main technique I'll be chatting about tonight is called SBRT, or stereotactic body radiation therapy. And in essence, this is taking the much longer form of radiation that people are generally more familiar with. If they know lung radiation at all, they're familiar with 6 or 7 weeks of radiation, which we still do, especially for more advanced radiation. But if we're picking up one of these early nodules with great screening and all these things, then we're narrowing the treatment down to, generally speaking, either surgery or this technique here. And this technique is usually done as either 3 treatments or 5 treatments. They are not invasive. They're really shooting X-rays from coming around the body and having them converge on the spot. So in this case here, you have a tumor which is towards the midline, near to the spine here, and able to approach this with, I think this treatment itself was done in 5 treatments, for example, and very, very high cure rates with that. I'll just skip ahead here and say, what kind of success are we having, just for frame of reference. So what's interesting is when we were using for these early nodules, so if you look at this picture here, here's a nodule which we approach quite easily now, but if we used radiation 15 or 20 years ago, we would have brought that person for 7 weeks of radiation, and the fields would have been bigger, toxicity would have been higher, and our success rate was only about 60% or so. And so really a bad combination. But with these newer techniques, you're talking about cure rates, I would say, in the short term of 90, 95, even up to 97%. And even actually, we follow these longer, these rates tend to maintain themselves with only a little bit of drift over time. So it's a very powerful option. And it's especially easy when tumors are a little more towards the periphery. So when they're closer to the center of the chest, we have to be a little, usually a little lower with the dose, or spread out a little bit more. And when it's a little more towards the sides, we can become a little more aggressive. And so great control rates with fairly limited side effects. People often ask about radiation versus surgery. And I would say that really for people who are what we call medically operable, our preference still is surgery. We've tried to look at it in a more rigorous way. This is a slide that shows 2 trials that were done as more randomized trials that made the 2 look actually very similar, perhaps even favoring the radiation, but they were such small numbers, and there are other data that are out there that strongly suggest that maybe surgery is a little bit better. So again, if people are medically fit, we tend to lead with surgery, but if they can't do surgery or refusing surgery, then we know that radiation is a great additional option. How about oligometastatic? So this the second topic I'll jump into. This is kind of the other end of the spectrum. These are patients where it started in the lung, but we're picking up later, and it has gone to other sites in the body. And I think we'll hear a little more from Dr. Lee about this topic as well, I believe. But I think the approach before was mainly, and I'm oversimplifying here a little bit, but mainly, well, it's spread around the body. What can we just do around the body? And there's not a whole lot else we can do to be a little more aggressive. But now what we're seeing is, at least in certain circumstances, if the number of spots that are around the body is on the small side, that yes, we still want to do something that's systemic and is covering the whole body, but we can also have a benefit from getting a little more aggressive with those spots. And so there are 2 trials that I'll highlight here. The first one asked the question, it's called the Sabre Comet trial, but it's asking the question, what if if you just had 1 to 5 of these spots outside of the lung, what if we hit all of those ones? How would we do compared to just regular care? And great trial, followed patients out a good number of years. And what they noticed is there was a very significant survival advantage to going and nipping those spots before they had a chance to grow up. And on average in this trial was 41 months versus 28 months. The second question that was asked was, okay, what if we also treat the primary site? What if we treat that lung spot that was the originator of these lesions? Is this irrelevant because the horse has already left the barn, and so just forget about that? Or do we get a benefit from what they call local consolidative therapy? And this one, they limit it to people who had 3 or fewer metastatic sites and had been really responding basically to their systemic therapy. So they took those patients, treated the primary site with either radiation or surgery. Mostly people got radiation in this trial, but could have been either. And again, very impressive survival benefit, 41 months versus 17 months. So this is a kind of a concept that would have been almost unthinkable 15 or 20 years ago, but now with better trials and more access to great surgical techniques, more access to these sophisticated radiation techniques, we're seeing that we can get more aggressive even in metastatic disease. The National Group for Radiation Oncology is called ASTRO, and the annual meeting actually just happened a few weeks ago. And this slide's a little bit overly busy, but just called a few things just to talk for a second about where we're looking to be creative and find out more in our space. So one thing that we've been struggling with are what are called ultracentral tumors. What about a cancer that's right next to the airway or right next to the esophagus? What we know is that when patients were treated with those really high doses of 3 or 5 treatments, it worked pretty well, but they were really having a lot of very serious complications. In fact, even a few deaths that occurred in those trials. And so what we are learning is we can still be aggressive, thankfully, but we're going to back it off. We're going to go from 3 or 5 treatments to 15 treatments and use a smaller dose per day. Not quite as high a chance of controlling that spot, but still quite high and much safer. So we continue to look at that topic, and there's just some news on that a few weeks ago. The other element is, when we try to treat an early lung nodule, there's always, we look at the mediastinum, that center part of the chest, usually with imaging or sometimes a surgical technique. But we know that despite the best workup, the risk of there being something hiding in the lymph node area is definitely not zero. So even if we do a fantastic job with the lung nodule, sometimes something will creep there. And then the question is, well, what are we going to do? Is all is lost then because it got there, or can we do something? So in some of the SBRT trials, one of the quoted figures for that kind of recurrence rate in the lymph nodes is 8%. And what we're seeing from some additional data is, yeah, we should go aggressively after the lymph node. We should probably use the more like 6 to 7 week course of radiation with chemotherapy and follow it with some immunotherapy. And the cure rate does definitely go down by quite a bit when cancer escapes into lymph nodes, but we can do a lot better with being aggressive than not. In one particular trial that was shown, they got up to 37 months versus 7 months. Obviously, we want these numbers to be even higher than that, but at least we're seeing a big difference by, again, being appropriately aggressive, I guess is the message there. And the last topic is re-irradiation. The idea of, hey, once you've been radiated, you can never be radiated again was a common saying some years ago, and sometimes it still holds true. But we're starting to appreciate more and more that if there's been usually more than 12 months, but in some situations 6 months of interval, and depending on what the spot is near, sometimes we again do have a chance to go after a new spot with radiation that's lay adjacent or even right in an area that was treated before. And these are never easy treatments. They really require a sophisticated team, like a multidisciplinary team, like Dr. Blasberg and myself, really kind of talking through the case and saying, okay, what's really the best option here? So we're not just blindly re-irradiating everybody, but it's nice to know that in selected cases, we really do have that option now, and it's much safer than was originally thought with the help of these more sophisticated techniques. And just a quick slide here in terms of trials that we're actually looking at or enrolling in Yale. One of them is looking at those central tumors and looking to see a different scheme for using 3 treatments as a safe option. Another one is looking at SBRT, trying to combine it with immunotherapy, which is exciting and is open. Actually, is going to open soon in Greenwich. And we have another one with SBRT and immunotherapy, which is open in our system, but that one's just open in New Haven. So great, again, multidisciplinary kind of research forward, cutting edge approach, trying to move some of these exciting things from surgery, radiation, and medical oncology together to have the best for our patients. And I believe my last slide here is just, and I'm happy to talk about this later if anyone has questions, but these are just For instance, 3 of the kind of famous machines that are out there for lung treatments, the TrueBeam, which I showed earlier that we have here at Greenwich, a proton machine, closest one to here is down in East Harlem. This is a very different way of shooting particles into the body to deliver the radiation. And then the CyberKnife machine that often has a lot of advertising around it, that is a miniaturized version of a radiation machine mounted onto a robot arm to help move around from different angles and shoot little pencil beam X-rays. And all 3 of these, depending on the case, can be appropriate for lung treatments, and all highly sophisticated. And that's it for me. Let me stop sharing. I'll turn over to Dr. Lee.
Okay, thank you very much, Bruce. All right, let me see how I can share my screen. All right. Okay, so as a medical oncologist, my job will be to talk to you about chemotherapy. So you've heard from Emily and Dr. Blasberg about the importance of early diagnosis of lung cancer. The survival impinges greatly on whether a person is diagnosed with cancer in an early stage or whether the cancer is advanced. But as you have been already shown, more than half of the patients at the time of the diagnosis are already found to have distant or late stage lung cancer. So unfortunately, that means that we do not have the ability to offer curative therapy, whether it be through surgery or through radiation. So the best treatment option for those patients are chemotherapy. So it's just several quick basic discussion about chemotherapy. So chemotherapy refers to any medications, any chemical that kills cancer. When we use the word chemotherapy, and most of us have certain ideas about what chemotherapy is. Chemotherapy are nasty drugs. They cause hair loss. They can cause nausea. They will cause blood cell to decline. So that's what we think of chemotherapy. And that's probably a fair description of cytotoxic chemotherapy. Now, I'm not going to go into the history of chemotherapy, which I think is fascinating. There's a wonderful book written by a physician. His name is Siddhartha Mukherjee, and the name of the book is The Emperor of All Maladies. I strongly recommend anybody to read that book. It gives a wonderful history of oncology and the history of development of chemotherapy. So since the chemotherapy was first thought of, developed since the mid to early 20th century, until very recently, it referred to chemicals that killed rapidly dividing cells. So generally, cancers are rapidly dividing, but also means killing a lot of healthy, good cells as well. So for many years, decades, patients and clinicians have thought, well, how can we make our treatment be much more specific, directing towards the cancer? And that has been the goal of oncologists for decades. So what happened? Breakthroughs. Breakthroughs occurred in the late 1990s. First occurred in 1997 with development and approval of a medication called rituximab, which also was known as Rituxan. It was different than all the traditional chemotherapy medication. It was an engineered antibody, what they called a monoclonal antibody. They got a bunch of mice to generate this antibody against a substance called CD20 that was present on a specific type of cell called B lymphocytes. So there's a cancer called non-Hodgkin's. There is a cancer called non-Hodgkin's lymphoma, which is a cancer of B lymphocytes. And this antibody specifically targeted only the B lymphocytes, meaning essentially the cancer. And yes, a few non-cancerous lymphocytes were hit, but this medication didn't produce any of those toxic side effects that that we all are accustomed to: nausea, hair loss. it was almost too good to be true, but there we have it. We had a medication that finally specifically targeted the disease without causing collateral damage. When we still use it. Now, beyond therapy for diffuse large B-cell lymphoma, as well as low-grade lymphoma, is also used in autoimmune disease. As a matter of fact, I believe WHO, World Health Organization, listed as one of the essential medications globally. Next breakthrough came through in 2000. By the way, 1999 is when I started my fellowship, so it's a memorable year. Next breakthrough happened in 2001, incidentally, the year that I left NYU and came to practice in Greenwich. So in 2001, FDA approved a medication called imatinib, also known as the commercial name of Gleevec. This was a game changer. Cancer called chronic myelogenous leukemia until this point had been a uniformly fatal cancer. From the onset of diagnosis, a patient typically had about 30 months, after which the cancer would progress into the accelerated phase, mimicking acute leukemia, and I mean, that really was it. Now, the defining characteristic of this chronic myelogenous leukemia is a mutation that occurs when a portion of the chromosome moves from one chromosome to the next. And that creates a mutant enzyme, mutant tyrosine kinase. And the scientists devised a medication that specifically blocked this enzyme. And lo and behold, patients, nearly everyone, went into remission and stayed in remission. And over the last 20 years, better versions of this medication have been developed. And now, when a person is diagnosed with chronic myelogenous leukemia, our expectation is that they will go into complete remission with no evidence of leukemic cells. Because this medication has been around for so long, and because so many people have stayed in remission, now there is real thought that many of our patients may be cured, and they may actually be able to stop the medication, which is really incredible. I think the changes, the advancement that has come about in the last 20 years. So what have the science over the last 20 years have brought us? Improvement in these targeted therapies. So through technology of gene sequencing, we are able to look for and find what are called driver mutations. So look at it, think of it like this. Not all, but many cancers become what they become and do what they do because there is a on switch that is just on. In normal biology, the switch is on when you need to, and it is off. There's a regulation. But that when the regulation disappears, these switches on all the time. And these driver mutations are exactly that. And by locating these driver mutations, at times, a medication or chemical has been developed to target these specific mutations, leading to effective treatment of various cancers. And along with this, there have been great improvements in developing detection tools. So in the past, we would need a sample of a tumor from a biopsy or what have you, and run the test to see whether these driver mutations are available. Over the last several years, and that biopsies, as many people may know, are not particularly pleasant. It requires some sort of an invasive procedure. And even then, we couldn't get adequate amount of tumor sample, and it was a challenge. But one of the great advancements in the last several years have been development of something called liquid biopsy, where you can just take a sample of blood and run similar analysis to see whether there are targetable mutations. So what you see in this very busy page, and I don't even know whether you can see all of it, are roughly 10 or so targetable mutations that have been discovered in non-small cell lung cancer just in the last 20 years. So since 2001, these mutations have been developed and discovered, and many of them only in the last several years. So I know that at least one of you would like me to go into more of a detail on one specific mutation, but again, that's really not the purpose of my talk. This is a listing of all the different mutations that are out there, including the RET mutation that is often found in not just lung cancers, but endocrine cancers, something called medullary thyroid cancers, and there are targeted therapies that are specifically designed for patients with these mutations, as well as mutations of ROS1, ALK, KRAS, and many more are in development. So what does it all mean? Now, is everything great? Well, not quite. So in one study, these targetable mutations were found only about 64% of the time among a series of 1,000 lung cancer patients that were looked at. Those who had a targeted mutation where there was a treatment, the median survival was 3.5 years. If you didn't have a driver or this targetable mutation, median survival was two years. So there's a significant difference in the overall outcome. So I think that one of the goal and the hope is that with additional research that we will be able to discover additional mutations, more potential targets, leading to better results and increased survival for our patients. Another important development. So we talked about these monoclonal antibodies, and we talked about targeted mutations. The next great development or class of new cancer therapy or chemotherapy are something called checkpoint inhibitors, or also known as immunotherapy. Plainly put, we have immune cells called T cells that are designed to scour our body, look for infections, foreign things, and damaged cells like cancer cells. And they do a good job. They do destroy many cells that would eventually become cancer. But many cancer cells have been able to avoid these T cells by developing something called checkpoint inhibition. That is to say that they put on a disguise saying that, oh, I'm one of the good guys, I'm fine. Just go somewhere else. So development of this checkpoint inhibitor, developed by scientists at Yale, actually, led to development of immunotherapy, the medications that are listed on this right-sided column here, that have been really been a game changer for many cancers, namely melanoma, kidney cancers, and of course, lung cancers being included in that group. And again, many more agents are in development, and there's an active research that is going on in this area of immunotherapy. So what does the future hold for us? What do I see? Well, as you know, you've already heard from my colleagues about the importance of lung cancer screening, and the advancement in surgical and radiation techniques. So what I hope to see in the future, hopefully before I retire, is improvements in early detection. Besides the CT scan, maybe there will be serum blood tests that'll complement CT scans so that we have greater sensitivity and specificity, or when a person is found to have a nodule, maybe a blood test can help us determine whether this is something that requires more attention or not. And discovery of more driver mutations, more targets. Under the best, that's 64%. I mean, out of 1,000 people, only 64% had targetable mutations. Well, maybe that's because we just have yet to discover more mutations, and hopefully that'll come in the next several years. And development of more mutations means hopefully more targets. And also with the targets that we have, I mean, if you have a targetable mutation, well, why can't they live forever? Well, because eventually the treatments fail for a variety of different reasons. And maybe if we were to develop multiple medications for that target, we can overcome the resistance. So I think these are the advancements that I'm hoping for in the future. And I'm very happy to say that my colleagues at Smilow and New Haven and are actively working on investigational trials, and we have many trials that are open here that we can offer to our patients. And the end goal being that obviously improvement in survival and better control over cancer. So that's the didactic portion of our discussion this evening, and I will see if there are any questions. I know it's quite late. If you do have any questions and maybe you don't feel that this is the right time to address us, please there will be links. Feel free to contact us and let us know if you have any concerns, you have any thoughts that you forgot to share or you just didn't want to bring it up this evening. We'll be happy to try to answer your questions.
And I think if anybody is eligible for lung cancer screening and hasn't yet been screened or has a friend or family member that would meet criteria and would like to be screened, you can reach out to us. I think Emily put up her email address before. It's a good way to, you could be in touch with us. Also, our updated website is ready or almost ready.
Yep, it's updated with there's an
Great.
email address listed on there as well as my phone number. So feel free to reach out if you have any questions or concerns or interested in getting connected with our program.
Sounds great.
Okay, well, then thank you everyone for attending this evening's session, and big thanks to my colleagues, Emily, Justin, and Bruce. So have a good night.
Thanks, everyone.
Good night, everyone.
Thank you.